I know you're a fairly involved worker in most of your cases anyways, but just maybe for other case managers, kind of what's the difference? What mindset, so to speak, did change for you to go from, a fairly involved worker to a very involved worker in some of these families?
Well, I value the collaboration, so I think that is probably the biggest piece is just, being more collaborative and just realizing that the end goal is getting the child back home with their family and what is needed to get that work done.
Okay.
And so I guess that's what I look at is how can I get that work done? How can I work with the rest of the team members to get that work done? Because there are
Right.
barriers that impact it, so
Right.
there might be other things that come up that need to be addressed.
As CIBS therapists, you play a unique role in this process, particularly partnering with the case manager. And so maybe talk a little bit about what the case manager can expect in terms of contact with you or the things you're doing that they should know about.
I was just going to say something along the same lines as what we were saying with parents. You can expect a lot of phone calls from us frequently, emails. You're expected to come and be part of the team when we do staffings at the RTC, and then less formal staffings before and after, so when the client is back home. You can expect supervisory involvement that isn't normally there in other cases. I think for me, I sometimes like to speak with my case managers that I'm working with on what are they seeing on the case. Since they're on this team and they're very active with the family, and in a lot of cases have worked with this family for a long time before I come into the picture, what do they know? What collateral information can they give me? And sometimes I also will reach to case managers to help me find paper documents, hard documents of collateral pieces that I need for diagnostic assessments. So helping with the legwork.
Yeah, I think case managers and other referring workers are going to find that we rely maybe even more heavily on them for that type of information, and that we are making a very active effort to pull them in to helping be a part of the team in our conceptualization of what we want to what we need to do with this family. And that may be a newer thing for them to be brought in on that, rather than us just telling them what we want to collaborate with them on that. So that maybe would be something that's a little different role for them as well.
And maybe, Mark, from a supervisor perspective, because I know there's often the tension between being over-involved in some cases versus servicing all the cases that might be on a case manager's caseload. How do you help direct a case manager in those situations? Because obviously there is a higher demand of the case manager's time and attention in these types of cases.
I think I mentioned earlier that you have to have more frequent supervision when you have a child in bridging, because things are happening so quickly, because you want to move quickly. And so, it doesn't really work to just check in once a month. I mean, you'd miss a whole phase of the program. And so by having that regular supervision, you have opportunity to help the case manager really stay in their role, because there's so much to do. It's easy to take on the role of another party on the team. And really, the case manager is kind of like a traffic cop. Like you're describing, where you're saying to a parent, the place to get this answer is from the case manager at the facility. The place to get this answer is from the in-home family therapist. The place to get this answer. And I think when there's questions among team members, they typically come to the case manager. In some ways, you're directing what's happening. And so that's important. The other piece is this kind of narrow-mindedness about a very specific goal and very specific skill development, that you just got to keep bringing people back when they get distracted by other things going on that are of concern, but they're not at the same level of concern as the skill we're working on that can help a child be safe in their family home and continue to work on the therapy. So when issues come up, you got to just keep saying, that's concerning, here's our response, but let's get back to
Right.
the main thing.
Right, yep. So not only is it the higher level of supervision and support for the case manager, but I would imagine even as a supervisor that your need to be mindful of that process and to certainly receive support that you need in order to keep people on task.
Yeah, it's almost like when you're maybe a step removed as a supervisor, I think it's easier to not get caught up in the fray of all the things that come up moment to moment to moment. And say when, people, well, this happened, we're going, yeah, that's concerning, but tell me about how has the youth demonstrated that new skill? Have they
Right.
demonstrated it at home? Are they demonstrating it at the facility? Are they being reinforced when they do demonstrate it? And just not getting distracted.
Okay. And I know we've been talking about some of the challenges or even some of the benefits, but I'm wondering if you could articulate even more, like what are some of the things that the advantages of doing this type of work versus services as usual? For instance, a kid just going to an RTC and receiving the services they typically would give kids.
Well, I think what I see as a benefit is that families become more aware of kind of some of the differences and the difficulties that they have in their own family system. And so they're faced with it because it's more frequent contact. And so they're having to be more open about it and needing to look at their own issues or look at the dynamics to make some changes. And then the other thing that I see is that parents and children are able to practice skills right away. So they are able to have more frequent visits and contacts and getting back out in their community, practicing those skills, whereas if they're at a faraway residential treatment center, that's a little bit more difficult to manage frequently. And so I think that's important is, they get out, they practice the skills, and then they come back, and do some more therapy around it and address the concerns, and then they're moving faster. They're
Right.
addressing it right away in the moment.
I think that's a great point because the pace of involvement in these cases is much faster. There's so much more happening. In part, I think because the in-home therapist is in there on a very frequent basis, giving you feedback about case updates. The RTC is feeding information into this process, and it is accelerated, so to speak, compared to a typical case.
Absolutely.
Good. Okay. Mark, from your perspective, what are some of the additional challenges that this model provides, particularly in a case manager role?
It's so demanding on families for their time and resource that's the other role that we're playing as the case management providers. There's a bunch of barriers to overcome. I mean, you have to free families up so that they can work this intensively, so they can, go to the facility and be with their youth and have the in-home worker at home. So in some instances, we do a process called family decision-making, where we ask families to identify the supports in their life, and we bring them together with a paid facilitator that says, okay, during this process, all of a sudden we're making these demands on a parent. Sometimes it's a single parent, and they have other children, and their needs need to be met, and who's going to attend to that? And so we tried to bring a circle of support around families because we know we're placing a high demand on them. Other things, financially, transportation. Sometimes we're helping people with gas or, paying expenses because, this is an intensive, challenging time, and we want to get to the outcome. We want that youth back home.
Right.
And for me, that's the hallmark of this, that your family's together. Your youth is with you. They're not, at the other side of the state for a half a year. That's the biggest difference.
Right. I think one of the challenges I've seen for case managers is maybe the evolution of seeing themselves as part of the system. Oftentimes, case managers are seen as gatekeepers, or so they're referring clients to service. But within this model, they're really seen as part of the overall treatment of the family, for better or for worse. Because sometimes there may be situations where case manager, there may be a certain situation where a case manager's role may not be well defined, or perhaps goals aren't well defined. And so as part of treatment, we want to be addressing everyone, therapists, case managers, so to speak, RTC in that process. And so in some ways it's a shift for the case manager to see themselves as part of the overall treatment process, so to speak, rather than someone separate from that they refer to. And I'm wondering if that is something that you were aware of, or something that crossed your mind in this process.
You know, I guess I don't know that I've acknowledged that. I, as you know, have a very active role, so
Right.
that's kind of my demeanor anyways. And so I just feel I kind of get in the trenches
That's
with
good.
the client and the therapist, and we kind of just go to town and try to figure out how to get that child back home and
Right.
try to address the issues.
Great. And I think on a supervisor level, Mark, maybe speak a bit to that, because I know you're aware of that dynamic and just how.
You mentioned this idea of gatekeeper. We really work hard to not have a case manager in that role. We have a juvenile screening team that's required by rule that makes decisions about authorizing placement and the use of bridging or any other kind of placement. And we hope it frees case managers to get alongside parents, that they feel like that case manager is really an advocate on their behalf, that's standing with them as, you know, there's a bunch of new people coming in their life. And we, for the most part, have already had relationship with families. And so we think that we're facilitating the transfer of trust that the families placed in us to the other team members, which I think is a critical part of moving quickly. You know, if it's going to take you 3 months to establish rapport and trust, you're going to miss the boat in this thing. And so by making sure the case manager isn't the one saying yes or no to you get the service you're asking for, but they're in the role of advocating for the family what they're needing and really understanding their need, I think you get in that therapeutic line, and it sets you up to be one of the members of the treatment team.
Any final thoughts? Any final things that you'd like to leave with people about, particularly from a case manager role in doing this type of work?
I would say hope. I think that's the biggest thing, is that sometimes you're working with families, and some of the families I've worked with for a few years before they get to this level of concern and care for their child. And I think that what I've noticed is that they've got hope again. They feel like their family is back together. They feel like they're able to manage the child's mental health. They're feeling more safe. And so I think that's been the greatest and the best surprise that I've noticed throughout this process.
Great. Mark, any final thoughts?
Really along the same line, that what happens is families have the actual experience that they're the most critical ingredient to the youth success. It's not the most important thing is some facility parenting their child and bringing them to where they need to be. The parent's at the core of this change. And I think it's really empowering when they feel like, I'm really what made the difference, you know? And that's why my youth is with me. And so for young people to be able to sustain relationships with their peers, other supports they have in their community, because they're not gone for a really long time. You know, if you take a 14, 15, 16-year-old and they're not in regular relationship with people for 6 to 9 months, well, that relationship, more often than not, doesn't last. That's not really that helpful.
Right.
You know, that's another trauma, another stress. And so getting to it, addressing the concern that it's made it not safe for the youth to be in community and their family, building that skill, and having the family be such an instrumental part of that skill being developed makes them hopeful, makes them more confident that we can do this, we can be a family, and we can live together successfully.
Okay, great. Well, thank you so much, Mark and Sandy, for sharing your expertise on the CIBS model. And thank you for joining us for this segment where we talked about how the case manager plays a role within the overall treatment process in CIBS. As you have seen, Collaborative Intensive Bridging Services provides an intensive yet effective way of treating youth with behavior problems and the families they live in. This program helps to minimize the problems caused by placing a child outside the home and treats the problem behavior in the environment which it occurs. As our model continues to evolve, we look forward to continuing to provide high-quality, integrated care to the families we serve. For more information about CIBS, please contact us at contact@facts-mn.org.